All right, good evening, everyone, and thank you for joining us. My name is Eliana Landa, and I am the Physician Relations Specialist here at Rothman. Tonight's webinar is with Dr. Luke O, Sports Medicine Surgeon. Dr. O's office locations are in the Advent Health Training Center, Innovation Tower, and Winter Park. Topic that he will be covering this evening is how to treat ACL tears. And also, just for a few quick notes, at the bottom of your screen, you will see a Q&A icon where you can enter any questions that you may have throughout the presentation, and Dr. O will have time at the end to answer any of your questions that you may have. Also in the chat box, I will share Rothman's phone number if you would like to make an appointment, as well as my information for any assistance that you may need. This webinar is being recorded, and you will all be emailed the recording within a few days. So without further delay, I will pass this off to Dr. O. Welcome, Dr. O, and thank you for your time this evening.
Thank you very much, Eliana. Good evening, everybody. I want to talk to you today about ACL injuries, and this is really a guide for patients and families and to have an overview of ACL injury. I am a medical director of orthopedic sports medicine at Rothman Orthopedics in Florida, as well as the Advent Health Orthopedics Institute. I'm the medical director and head team orthopedic surgeon for the Orlando Magic. And I have faculty appointments at Harvard Medical School and Northeastern University. And I'm also a consultant for the Boston Red Sox, for whom I had been a team physician for 14 years before moving to Florida. So I moved to Orlando about a year and a half ago after a 14-year career at Harvard Medical School and Massachusetts General Hospital for both personal and professional reasons. I've had the pleasure and privilege of serving on the medical staff of the Patriots and collected a few championship rings along the way as well, and have many colleagues and friends and friendships that have formed through those experiences. And grateful to have moved to Orlando, the city beautiful, with wonderful weather, no shoveling snow in my future anymore, which I'm really excited about. I was fortunate to arrive here just as the Innovation Tower building was built and opened. Saw for the first set of patients in this building about a month after I arrived for this new job. Also was fortunate enough to arrive in time for the ribbon cutting ceremony for the $75 million Advent Health Training Center with the Orlando Magic practice. And we have a clinic there as well with physical therapy and imaging. And this was 7 weeks after I arrived in Orlando, and it was really exciting. It's an awesome opportunity for me to work alongside some fantastic colleagues at Rothman Orthopedics and to be able to take care of the Orlando Magic. So very grateful for opportunities here, and wanted to start off about talking about ACL injuries. And the statistics are that there are between 200,000 to 400,000 ACL reconstructions performed each year, depending on which source you look at. These are some high-level athletes who have sustained ACL injuries: Lindsey Vonn on the left and Tom Brady on the right. And in basketball, soccer, football, lacrosse, and many other pivoting injuries, including skiing and volleyball, there are athlete injuries that are tracked. And in basketball, this is unfortunately a common injury that has afflicted many of our star players. And so the topics that I want to address tonight is: what is the ACL and what does it do? How do athletes tear their ACL? How do you diagnose it? What are the treatment options? And what are the relevant advances in ACL surgery? And how do you determine readiness to return to sports? So the ACL is short for anterior cruciate ligament. And so in the center of the knee, there are two ligaments that cross each other and is in the shape of a cross. Hence, they're referred to as cruciate ligaments. One of them attaches in front of the other. And typically in anatomy, the location of the attachment that's referenced is the distal portion, meaning the further portion. So on the tibia bone, the ACL attaches in front of the the PCL, the posterior cruciate ligament. On the diagram on the left side, there are ligaments on the inside and the outside of the knee. Those are called collateral ligaments, and the MCL is the medial collateral ligament, and the LCL is the lateral collateral ligament. And in between the bones, the thigh bone and the shin bone are the menisci. There's a medial meniscus and a lateral meniscus that can also be injured at the time of an ACL tears. We won't be talking about combined injuries during this talk tonight, but that adds a level of complexity to the management of an injured knee when you have ligaments, perhaps more than one, that are injured in addition to meniscus tears. So the function of the ACL is to protect the knee from both anterior to posterior, meaning front to back motion of the two bones in relation to each other, as well as to hold the knee together during twisting and pivoting motions. And the video on the right side is going to demonstrate how the ligaments interact with each other and also with the two bones in order to stabilize the femur and the tibia. On the diagram on the left side, you see that a helmeted football player is tackling the knee from the front and from the side. And that maneuver is illegal now in football. That type of angle of attack to the knee typically results in ligament injuries, particularly the ACL is at risk. It can also cause hyperextension injuries, which is also another mechanism of injury. So we had been talking about some of the ways that you can injure the ACL. Typically, there's twisting component with pivoting or cutting, non-contact versus contact. So in the diagram on the prior slide, that was a contact injury, but it turns out that contact injuries only comprise about 20% of the causes for an ACL rupture, and 80% of cases are non-contact. So in fact, on the bottom left is Wes Welker. Everyone thought that he tore his ACL as a result of the tackle that happened about 2 seconds after the shot was taken. But in fact, if you slow down the film, because he had a defender attacking him to tackle him, you can see his eyes move. He had made a decision to change directions while he was in the air, but his body was going in the original direction that he was juking. And so as soon as his foot touched the turf, you see that he collapses, and then the defender lands on him. So in fact, he tore his ACL and therefore fell down, and then the defender reached him a split second after that. So it wasn't the tackle that caused that injury, it turns out. Hyperextension is also another mechanism of injury to tear the ACL. So how do you diagnose an ACL tear? There are a couple of different ways, and we have to use both the history as well as physical examination and imaging, and use all of the available information to make the diagnosis. So we already know that there's usually a twisting injury involved. The athlete many times will explain that there was a pop that they heard or felt, or a tearing sensation. There's pain, there's swelling, and there's difficulty weight bearing. So we teach our medical students and residents that there are certain types of injuries where the pattern is so classic that we call them basically telephone diagnoses. So if someone calls you on the telephone, you don't even have to see the athlete, and they say there was a football game and this athlete went down with a knee injury, heard a pop, had pain, there's a lot of swelling, and there's difficulty weight bearing, there's an 85% chance that that person has an ACL tear. So it's an ACL tear until proven otherwise at this point with this type of a history. Physical examination, effusion means swelling within the joint. There's limited range of motion because of pain and also guarding. The Lockman examination is named after Dr. Lockman from Temple University, who described the maneuver that you see on the lower left-hand side, where the knee is flexed. Actually, he described it to be a different flexion angle than what we use it now. He described it at the 20-degree flexion angle. We currently do it at 30 degrees, and we pull the tibia forward, and it moves anteriorly excessively, then you know there's an ACL rupture. because the ACL otherwise would tether it so that the tibia would not move forward. The anterior test is depicted on the right side, where you bend the knee to about 90 degrees or so, and you're pulling the tibia forward. And it's like opening up a drawer. If it moves without an endpoint, or does have an endpoint but moves with sufficient millimeters more than the contralateral side, that's considered a positive test. A pivot shift test is trying to take the leg and to try to cause a twisting as if the knee is undergoing a pivoting motion. And if the knee clunks in and out during that maneuver, that also demonstrates ACL insufficiency. Imaging, there are information that we can glean from both X-rays and MRI. Typically, if there is a concern for an ACL injury, then it's very common nowadays to get an MRI, but an X-ray should also be obtained because there's quite a bit of information that you can get from an X-ray, and sometimes it may be clearer to see on an X-ray than on an MRI. So on the upper right-hand corner, there's an X-ray of a knee where, pointing with my pointer now, there's a little piece of calcification, and that on the lateral side of the tibial plateau, which is the shin bone, that's an avulsion fracture that's associated with an ACL tear. That's called a Sagan fracture. On the left side, on the top, there's a chip of bone from the tibial tubercle. So that's the area where the ACL attaches to. So you can see that this individual has open growth plates. So this is a skeletally immature individual in their early teens. And at this age, sometimes the growth plate region or the tibial tubercle may actually be the weakest link. And when the energy that would typically create an ACL rupture goes through the knee, it may dissipate the forces by creating a fracture there. So this is the equivalent of an ACL tear in a young skeletally immature person. On the lower left-hand side, you see the two pictures here now. On the left side, you can see the fibers of the ACL that are intact. You can follow the line. And on the right side, on the torn one, you cannot see any tissue that are traversing the usual course of the ACL. The lower right-hand side here, what this is showing is that the bones are dark in this series of images. But there's a bone bruise, you see, that's white here on the back of the tibia and toward the front of the femur. So these are kissing lesions, and the way that this has happened is that the tibia, the shin bone, must have gone out toward the front sufficiently for it to then clunk back into place, and the back of the tibia hits this region to create the kissing lesions of the bone bruise. And on the right side, it's depicted by showing you that this ACL ligament has been ruptured, which then allows the tibia to move forward, and the back of the tibia can then hit the front of the femur. And so this is a classic bone bruise injury that tells us that there was an acute event that caused the ACL tear. So let's talk about some treatment options now. A question that we often hear is, do I absolutely need to have surgery? And there is a non-surgical treatment option, but there have to be certain criteria that are met in order for an individual to be considered for what's called the COPERS program. There's the option of a ligament repair versus reconstruction using a graft. If you're going to undergo a reconstruction with a graft, then there are autograft options versus allograft options. Autograft means tissue taken from the patient's own body to make a new ACL to insert it into the knee. Allograft is a cadaver, meaning a patient has passed away and donated tissue and sterilized for it to be used in reconstructive surgery. Autograft options. So with our own tissues, there are several different commonly used grafts for ACL reconstruction surgery. And we'll review that. Allograft options exist as well. There are also the possibility of combined injuries. In addition to an ACL tear, there could be a concomitant meniscus tear, there could be a cartilage defect, there could be other ligament injuries, such as the PCL or the MCL or the LCL or the posterolateral corner, or any combination or permutation that's possible. So let's talk a little bit about the non-surgical treatment, which is referred to as a COPERS program. And so the name comes from the fact that there's some individuals who, despite having an injury, are still able to cope well with that condition and able to render their knee more stable compared to others. And so if there is a coper, they may be able to undergo rehabilitation without surgery and enjoy a knee that is stable. Sometimes it does require that they decrease their own expectations for participation in high pivoting sports. So the potential coper should be, it says, demonstrate no more than one giving way episode since their injury. If the knee's giving way frequently, then that person is not demonstrating sufficient neuromuscular control to be considered a coper. Score 80% or higher on the knee outcome survey, activities of daily living scale, score 60% or higher on the global rating scale of perceived function that assesses a patient's own subjective assessment of what their knee can do and their confidence with their knee. Score 80% or higher on the 6-minute timed hop. So there's a hop testing that helps assess the neuromuscular status of the entire lower extremity, and they need to be able to perform well on those tests. Now, it turns out that the vast majority of people are not copers, and this is not something that an individual can choose and actively decide to be a coper or not. It's a combination of neuromuscular control as well as the reflexes that are there. And despite one particular individual's best efforts, you can't try to be a coper. You either are or are not, and that becomes very evident very early in the process of diagnosis. The vast majority of people will end up needing surgery in order to develop confidence in the knee and stability in their knee. So once an ACL tear is diagnosed and surgery is being planned, we need to optimize the condition of the knee in preparation for surgery. So research has shown that the best outcomes after surgery are enjoyed when the patient has surgery that meets the following conditions of their knee: that there's no longer an effusion or any type of swelling. There's no pain. The patient needs to have full range of motion and a normal walking gait. So this is typically achieved with about 3 weeks of physical therapy on average. And so at the time of diagnosis, everyone gets a physical therapy prescription and a plan to meet again in the office after about 3 weeks to assess the range of motion. Now, it should be stated that the patients typically, because they have pain, swelling, are not able to walk around, are usually not confident that they would be able to achieve these goals in 3 weeks. And also the explanation that basically we want the knee to be feeling, quote, normal before we schedule surgery. So for some people, that doesn't make much intuitive sense in the beginning to say, well, if my knee feels normal, why would I have surgery at that time? But if you push it and perform pivoting sports, typically there will be a giving way episode in most cases. So what about the repair versus reconstruct with a graft controversy? On the left-hand side, what you're seeing is that if you have a particular situation where the ACL is torn from the thigh bone, from the femur, then you can place sutures through the torn ACL ligament and reattach it to the femur with the use of suture anchors. There's also a big, thick suture tape that is attached from the femur down to the tibia to give it a crutch, if you will. It's a suture that acts as an additional tensile fighting force to protect the ligament so that the ligament is not the only one that has to withstand the stresses while it's undergoing healing. Now, the repair technique can only be successfully performed if it's an avulsion of one end or the other. But if it's a mid-substance rupture where you have tissue that look like the end of a mop on each side, then you cannot repair that successfully. The rest of the ligament tissue has to be strong enough so that you can reattach it to the bone. So if it's torn off the bone, a repair technique is possible. If it's torn at the mid substance, it is not. On the right side is a reconstruction with a patellar tendon graft. This is commonly referred to as a bone tendon bone graft because there's a piece of bone on either end of the patellar tendon. And after it's placed into the tunnel, in this case, these are metal interference screws that are used, but nowadays biocomposite dissolvable screws are used probably more often than the metal screws nowadays. And what we're doing is to put the metal screws in to the space that remains after you put the bone block into the tunnel that's been drilled. And by putting the screw in there, you are then squeezing that bone plug against the wall of the tunnel that was created, and that would result in bone-to-bone healing over time. So reconstruct with autograft versus allograft. So this is a diagram depicting the use of a patellar tendon bone graft, an autograft from the patient's own tissues. The central 1/3 of the patellar tendon is removed with a piece of bone on either end, and that gets inserted into the knee to replace the torn ACL ligament. On the left side here, this is showing the harvesting of the quadriceps tendon, which can also be used as an autograft tissue for ACL reconstruction. On the right-hand side is showing the location of the hamstring tendon that can be used for ACL graft as well. And for allograft, or cadaver tissue, all of these tissue types are available as allograft tissue, in addition to others, including posterior tibialis and anterior tibialis tendons as well. Achilles tendon allografts are also used and have been popular in the past. I think they're waning in their popularity nowadays, though. So in terms of graft fixation, you may ask, well, how do they get attached? And on the left-hand side, this is that description of the interference screw. Again, the bone plugs are inserted into the tunnel, and in the space that remains, you're putting in a screw that then squeezes and causes an interference fit to the bone plug that's in the tunnel. On the right-hand side is a button fixation. And what that means is that you place the graft into the tunnel, you drill a smaller drill hole through which a button slides out. You can pull the sutures out through there and tie it over a metal button on the cortex of the bone, and that confers quite a bit of stability. Now, what about rehab after surgery? There are 6 main phases, and that there's a pre-op phase that we talked about to optimize the knee in preparation for surgery. The phase 1 after surgery, typically patients are using crutches for protective weight bearing, as well as a hinged knee brace that allows you to walk while conferring some stability to the knee. Phase 2 is to get rid of the crutches and the brace and to work on strengthening as well as neuromuscular control over the lower extremity and core. Phase 3 is to start with a light jog, then to progress to a run and work on agility as well as landing mechanics. As you can see on the top there, the male patient is jumping off from a box, performing a box jump, and to learn to land with the best neuromuscular control and biomechanics so as not to increase the risk of additional stress going to the reconstructed graft. And phase 4 is return to sport, and phase 5 is always being aware of the preventative need against re-injury. So I want to make mention of this fascinating observation. So far, the tissues that have been used for reconstruction had been tendons, whether they come from a cadaver or whether they come from a patient's own body. The tendons, which are the portion that connects muscle to bone, whereas an ACL ligament connects bone to bone. So tendons and ligaments have different properties. Yet when you take a tendon and you create a new ACL out of it, there's an observation that the tendon tissue starts to undergo changes, and there's a transformation of sorts at the cellular level where it starts to look more and more like a ligament over time. And we call that process the ligamentization of tendon graft. And so the other interesting observation is that the tendons, upon insertion into the knee, demonstrate high tensile resistance loads. And in the early phase of healing, it stays quite strong. And in fact, it's a lot stronger than the strength of the original ACL. Then during the phase of healing, it gets weaker than the native ACL. And then over time, it recalibrates and becomes similar to the strength of the original ACL. And so that's why during week 5 to say several months afterward, the knee continues to be protected and there's a slower progression than what most athletes would like. And this is one of the reasons for that extra precaution. In terms of post-surgical rehab, when I was in medical school 25 years ago, there were many decisions made about return to sports based on chronological time that has passed from the time of surgery. Meaning, hey, it's been 9 months since your surgery, so you're good to go. Well, if you think about it, that doesn't make all that sense because different people would rehab at different rates based on their biology, physiology, and their motivation. And so as a result, what we've discovered is that goal-based post-surgical rehab is much more predictable in terms of following their progression to returning to various types of sports. There are a lot of different patient-reported outcome measures. They typically are expected to achieve 90% or better on those metrics. Quadricep strength, girth, and volume. We would like to be greater than 90% of the contralateral side. There are a variety of different hop tests, crossed hop test, time top, triple jump hop, standing broad jump hop, and we want to see the symmetry at greater than 90% of the contralateral uninjured side. Now, occasionally, there are some athletes where their contralateral uninjured side is as weak as their recently operated side. And so those are athletes who are identified as having a high risk of injuring the ACL on their currently uninjured side, but is at risk in the future. There are some on-field sports-specific exercises that are also included as well. And number 4 talks about the athlete having confidence in his or her ability to return to their sports. And so we are now much more aware and tracking the patient's psychological readiness to play. So those are situations where objectively a physician may say, hey, your knee feels stable, everything looks great, your quad strength is awesome, and your hop testing is outstanding. But the athlete says, but I don't trust my knee, I don't quite feel ready. And there has to be a convergence of readiness, both based on the subjective factors from the athlete as well as the clinicians. And so we are much better at doing that, say, 25 years ago. The other aspect that is important is there's always that specter of a re-injury, a re-rupture. And so there needs to be maintenance exercises. There needs to be an awareness. The neuromuscular control can wax and wane depending on the effort. And it's like any other types of exercises that we would do. If you've been out of it for a while, then things atrophy, you get a little bit weaker. And you need to build that back up. You can't quite take time off and decide, hey, I'm going to go play back-to-back pick up basketball games and have full confidence that you won't sustain an injury. So wanted to open up the field for questions because I heard that there were some questions that were submitted in advance as well. And so please feel free to place them into the chat or in the Q&A section. And for continued interaction with me, feel free to reach out to me through either Instagram or Facebook. And for additional information, you can go to that link that's listed there on the bit.ly link. Thank you very much. So Eliana, I think I would stop sharing and review some questions. Let me review the chat here. Okay, and then question and answer. All right, let me start reading the first. I've had an ACL reconstruction with hamstring in 2011 and just tore it in March 2024, always when playing soccer. Sorry to hear that. Nothing else is damaged in the knee. That's good. What would be the general recommendation moving forward to, again, hamstring reconstruction surgery, or rather use patella tendon? My lifestyle is I play soccer, surf, run, bike, dance. My plan, stop playing soccer, continue surfing, dancing, active lifestyle. With that, when do you prefer hamstring or patellar tendon for ACL reconstruction? Okay, so the graft options, the discussion about graft options is described in the orthopedic community as a discussion about one's religion. And depending on what school you'll come to, you'll find people who are very passionate about one graft type or another. Having said that, I'll share with you my own personal perspectives. My personal preference is to use a patellar tendon graft for a couple of reasons. There's some long-term studies that show that all of the autograft options are, quote, stronger or have a lower re-rupture rate than cadaver grafts for athletes from their teens to about the age of 40. Interestingly, after the age of 40, regardless of whether you have an allograft or an autograft, the re-rupture risk seems to be about the same. So the way we interpret that is that athletes above the age of 40 are not pushing it as hard as they did when they were teenagers or in their 20s. So therefore, for teenagers and for those in their 20s, I recommend strongly to use their autograft. I really don't like even discussing the cadaver allograft as an option. For individuals above the age of 40, we start having discussions about allograft. You don't have the donor site morbidity. You're not robbing Paul to pay Peter. It's one fewer thing to rehab, and there is less pain, usually with a smaller scar as well. Among the autografts, again, we have all of these autografts options because they have all shown to be quite sufficient in rendering stability to the knee. However, if we are going to be picayune and compare, in longer term studies, the hamstring autograft does have a slightly higher revision rate, revision meaning redo surgery. And so if this study had been done several times where it was a survey study asking the team physicians of all of the different professional teams in a given league. And when they did the survey in the NFL, MLB, NHL, MLS, and the NBA, about 85% of the surgeons indicated that they preferred the patellar tendon. Now, having said that, I will tell you why that study is a bit flawed, because it makes you seem like every doctor from every professional team has a strong preference for a patellar tendon. But as this was the case for myself and many of my colleagues, sometimes those doctors take care of more than one team and maybe taking care of multiple teams, including teams from different leagues. And so it was, many of the same surgeons who were surveyed over and over again. Having said that, if you had your initial surgery with a hamstring tendon autograft, and if you were to see me and ask for my opinion on a revision graft option, my recommendation would be to use the patellar tendon autograft. Quadriceps is quite a good choice as well. It doesn't have as long of a track record. Patellar tendon autograft has been used for 40 plus decades, 40 plus years. And the quadriceps autograft came onto the scene probably in the past 15, 20 years. Next question here is, what's the opinion on doing a revision of ALL plus patellar tendon reconstruction of ACL as a second ACL reconstruction surgery for the second ACL tear occurred? First tear was reconstructed with a hamstring procedure. So for those of you who may not know, ALL, the anterolateral ligament, is an additional structure that can confer stability by restricting the rotational component of the tibia. There's some colleagues of mine who feel that in a revision redo setting, you want to throw the kitchen sink at it. In every single case of a redo surgery, I have colleagues who insist on performing that additional ligament augmentation. Now, there's some controversy about it. The native ligament tissue and what a surgeon can put in sometimes biomechanically don't function in exactly the same way. Live tissues do have the ability to be created and developed in a way where it may not be completely isometric. But a surgeon, as a human surgeon, we can only place grafts that are isometric. So it may not necessarily recreate the function exactly. There have been some biomechanical studies to show that if it's placed even a millimeter off the precise location, it's possible once you cycle the knee that the ALL that you have reconstructed will be disrupted in the recovery room. That it's that finicky. So the alternative to the ALL reconstruction is something called an LET, the lateral extra-articular tenodesis, which, by the way, is actually my preferred augmentation technique because the biomechanical data for ALL reconstruction does seem to suggest that it can be disrupted very early in the rehab process. So for me, I assess what the reason was for the failure of the original surgery. The most common failure type is due to what's called vertical tunnel placement or inappropriate tunnel placement. So if the tunnels are not in the right place, the graft will, over time, over many cycles, will fail. And so if the problem was an obvious tunnel misplacement, which you'll be surprised even to this day, that is rather common and still probably the most common reason why grafts fail. As long as it's not a re-rupture, meaning if you get a surgery that's done perfectly well, it's possible with pivoting sports for you to re-rupture again in the same way that you ruptured in the first place the ligament that God gave you or that your mother gave you. So that we have to be careful about that, distinguishing that. There's a re-injury that is possible, but if it's not a strong enough force and you have re-ruptured it, it potentially could have been a failure of technique. And so if it's a tunnel problem, then I don't often add an lateral extra-articular tenodesis. For patients who have extreme hyperextension, hyperextension, as we discussed, is a risk factor for ACL injury. So for patients with a high degree of hyperextension, I add that lateral extra-articular tenodesis. So, although we have general algorithms that we're sharing with you tonight, and those are, I should say, my personal algorithms, there can be subtle individual differences from patient to patient and situation to situation where we would have to consider the larger picture as well. The other thing that wasn't mentioned, but something that we need to search whenever there's a failed ACL surgery is also about the anatomy of knee alignment. So it's possible for some people to have different tibial slopes that can also render a higher risk of re-injury for an ACL in a knee of that type of bony anatomy. So how long after the full ACL tear should you wait until you do the reconstruction? So some general principles. If you have an ACL tear, you're going to swell up, you have a lot of inflammation going on, you're going to have restricted range of motion, and that process starts several hours after your injury. So imagine this now. If you have a swollen knee that's hot and bothered and you don't have good range of motion, and you have surgery and you have a surgeon-induced trauma to the knee, and you develop a little more range stiffness and a little bit more inflammation, and you lose a couple more degrees from the knee that already had compromised range of motion, then you're in trouble. So as a result, that's why we have people undergo prehab with 3 weeks of, on average, 3 weeks of physical therapy to make their knees quiescent prior to having surgery. But following that logic, let's say that you have a unique situation, say that exists in only certain centers in the world, where you happen to have a surgical center at the bottom of the mountain, and you tear the ACL, you ride the with ski patrol directly into that surgery center, and you have surgery immediately. That could be theoretically another way for you to have surgery with a knee that's not swollen, painful with restricted range of motion. So you do have a very small window immediately as you have the injury to potentially have surgery at that time. But in most cases, at least that's not where I ski. So you would need to return home, get a consultation, go to the emergency room, get x-rays. By the time you get referred to an orthopedic surgeon, clearly the knee is already swollen and painful. So that's usually the timing of it. But in the usual scenario, it would be prehab, optimize the knee for range of motion, no swelling, normal gait, no pain, and that's when you would schedule the surgery. Can an ACL repair be done on a reconstructed ACL hamstring that is fully torn? So let me make sure I understand this question correctly. So there was already a reconstructed ACL with a hamstring graft, and it's torn again. Can an ACL repair be performed? So not in the way that I had described before. So usually when you have a hamstring graft or any other graft that has undergone surgery, but particularly the hamstring, when it ruptures, it looks like, like horsehair, like it's split up into its individual fibers, and the tissue quality is poor. So I would typically not recommend repairing a prior hamstring graft ACL that is torn. So the best candidates for repair are young athletes. The initial indications were teenagers, and now it's expanding beyond to people in their 20s, 30s, and even older. But the quality of the tissue has to be good. And so when you're scheduling someone for an ACL repair, there also has to be discussion that, hey, when we go into the knee and take a look and the tissue quality is poor, then we may have to perform an ACL reconstruction with a graft because the tissue quality is simply not good enough. And remember, the ACL has to be torn off the bone for ideally to be a good candidate for the repair rather than mid-substance rupture. Sometimes on the MRI, it looks like it tore off the femur, but when you go in there, the first centimeter and a half of the tissue is poor quality, then that would not be a good situation to undergo repair. There's more and more research of ACL tears healing spontaneously. That's incorrect, by the way, and I'll talk about that. What is your opinion on this? Is it possible that ACL tears can heal on their own? If so, what if the ACL is already a reconstructed one, hamstring, what are the chances of healing? Yeah, so that's the easier question to answer. If the ACL is already a reconstructed one and you re-injure it, it's not healing, my friend. Sorry to tell you that. again, when you go in and look at it with the arthroscope, it gets split into its individual fibers, and usually it's undergone quite a bit of plastic deformation if it's not fully ruptured and exploded looking. So there's more and more research of ACL tears healing spontaneously. So I think what you're referring to are some of the studies that were done using MRI to assess them. So let me share with you the experiences from even before those studies have been published. If you have somebody who had an ACL tear years ago, and for whatever reason, they were busy or they didn't have insurance and they didn't get surgery done on it, but yet their knee gives way. And I get this story all the time. 3 to 5 years later, they said, I finally got a job and I have good insurance now, and I want to get this thing fixed because my knee has been unstable all this time. So you would order a new MRI, and lo and behold, the new MRI shows what appears to be an intact ACL. There are fibers there. There's been scarring going on. There's something that connects point A to point B on where the ACL is supposed to be located. Yet what's fascinating is when I perform a Lockman maneuver or an anterior drawer, it's loose. And when I do a pivot shift, it's loose. So would you consider that a spontaneously healed ACL? Because the MRI showed that you have scars that connects point A to point B, but functionally it's not working, it's insufficient. So the research studies that are MRI based have that as a problem, is that we know from clinical experience that MRIs that make it appear like it's, quote, healed are functionally incompetent. So I don't really think that it can heal spontaneously. I will tell you what I think can happen. There have been patients who tore their ACL. Time goes on, and the ACL can get scarred down to the PCL. So it's torn off the bone, but it's scarred to the ACL, such that when you pull the tibia, there's what appears to be a muted Lockman or a negative Lockman, like essentially a normal Lockman and anterior drawer exam. The real question is, when you try to pivot them, does their knee stay stable? And even in the office, it may be hard to make them pivot, but the force that I can impart on the knee during a pivot shift examination in the office is different than their body weight, the speed, and the momentum of them playing basketball or soccer. So those are all part of the assessments. If there's a patient who says, hey, yeah, so you're saying that you can't elicit that instability, but I know I can't play basketball, I can't pivot, I can't turn the corner when I'm playing soccer, I can't cut and pivot when I'm running a route playing football. So all of this has to be taken into consideration because I think we need to make sure that we're not over operating on people. And as we mentioned before, we do want to identify the copers, but the successful copers, as I've mentioned, have also made a decision, either consciously or subconsciously, that they may decide not to return to the really hard pivoting sports, but stay with other types of sports that their knee can handle. And so that's why it's important to understand the individualized and customized approach to having a consultation with each individual athlete that's got an injury. Is there any data information on treating ACL tears without surgery? What would be a good protocol to do so? PT diet, et cetera. Okay, so I think we answered that already. Is it standard of care at Rothman Orthopedics assess for COPR status prior to surgery? So that can also be assessed as part of the prehab program. So during the prehab, you're undergoing physical therapy, rehabilitation, and we see them back after surgery, or at least I do, to assess for the range of motion normalization, normal gait, and also at that point is the best time, and maybe better time certainly than at the time of injury, because there isn't as much pain and guarding nor swelling, to perform the different types of physical examination maneuvers. So there have been patients who came back thinking they're going to schedule surgery, and I explained to them, I said, you know something, your knee's actually a lot more stable than I anticipated. And I start talking to about whether or not they're interested in trialing a COPERS program. And as you may guess, people, I'm 52, turning 53 this year, individuals who are at similar stages in life tend to say, hey, yeah, you know what, I might want to try that so that I don't necessarily need to miss work, and I'm not playing in the harshest pivoting environments in different leagues and what have you. Usually, younger athletes are fearful of a re-injury in the future if they go through a COPER program now. And so that's also part of the decision making too, right? So they don't want to go through a COPER program, go back to their sport, and then have it give way and then come back for surgery, which tends to be for most patients, they're really their major concern. Yeah, but for me, when they come back after their prehab, before we typically it's when we schedule them for surgery, that's the time that when I perform that assessment myself. Thank you, Meredith, for that question. We got Michael here, Kosubek. What is the success rate of a second reconstruction versus a first reconstruction surgery? So there's no surgery that there's no second surgery that is as successful as a first index surgery, and that's just not in orthopedics, but any surgery that you can imagine, whether it's GI, general surgery, ENT, plastic surgery, brain surgery. The second surgery is always a little bit just tougher for multiple reasons with a higher complication rate as well, whether it's infection or some other scarring and that sort of thing. What is the most common cause for failure of reconstruction? We mentioned that. That's misplaced tunnels. But we briefly went through some of the other types of things as well, which is, their sport that they're going back to. As you know, we have contact sports, and then we have collision sports. So collision sports are those that have hitting other people as part of the rules. So football, ice hockey, rugby, MMA, there's a higher rate of failure just by the nature of the sport. The allograft, if you put in a cadaver allograft in a teenager or someone in their 20s, I would expect them to have a much higher failure rate. Okay, Dan. Are there any supplements, including hormones, athletes or individual can take if medically cleared to enhance the healing recovery process? Well, that's a little controversial. There are, supplements are not FDA regulated, so the manufacturers can't even confirm that from lot number to not lot number that they have the same percentage of the active ingredient, whatever that may be. So that's the nature of supplements in general. So it's not regulated. Hormones, there have been some research done about that. The problem with hormone use is that there are usually side effects. So unless you know how to dose things perfectly, you can end up having other hormone-related complications, which you may not wish to have. So typically, we don't use that. That's not a standard part of our practice. And if for people who are interested in that, they would have to go look for those specialists, usually who are self-proclaimed. And so buyer beware. So far, I incorporate blood flow restricting devices as opposed to rehab, strength, and conditioning coach to promote blood flow to the affected tissue. Great. That sounds fine. We use it too. All right, Mary Serrato, in your experience, which type of graft has the, oh, it just got shifted, has the least incidence of recurrence? So again, let me just put this into the framework. If Jimmy Johnson and I needed to get into a car race, and they give me a Ferrari and you give him a Yugo, I'm fairly certain he will win. So the reason why we have so many different grafts options are that they can all work well. We just talked about the fact that malpositioned tunnels are by far and away the number one reason for a failed reconstruction that is not from a re-injury. And so it doesn't matter what graft you use, you put it in the wrong spot, it ain't gonna work. So I think that's what's imperative. You need to find the surgeon who's experienced, who's good, who understands anatomy. And I think that's why if you should seek out a sports medicine fellowship trained surgeon rather than a general surgeon general orthopedic surgeon who performs this, a couple times a year. Taylor, hello. What percent of knee injuries are just isolated grade 3 MCL tears? I guess because we have a sports medicine practice, we see quite a bit. There are, if you have a pure valgus injury, we do see people with isolated grade 3s. The grade 3 MCL tears clearly had a higher level of energy. So, there is a significant percentage of people with grade 3 MCL tears who have concomitant cartilage contusions, cartilage defects, medial meniscus tears, and ACL tears. But I don't know that I have a number that I can give you per se, but that's the situation. Okay. Katie Wu says, will the patellar tendon that give you graft from regenerate? So the central 1/3 defect will fill in typically with scar tissue, and there are some fibers that make it look like tendon, but it's not of the same quality and architecture as the native tendon, to the point where it would give any surgeon confidence to go back and harvest it again and use it as a graft in a future surgery. Hope that makes sense. So, it does fill in with some stuff, but it's not really good stuff. Does the ACL graft deteriorate over time? I had ACL reconstruction 7 years ago with allograft. Yes, so allograft, we talked about the failures of allograft. That's precisely the reason why we would prefer autograft especially in younger people. Allograft tissue in general can degenerate over time. That's both soft tissue and bone. There's a percentage of those things happening that happen at a higher rate than autograft. I recently had an MRI and showed that the ACL has mild degeneration. What does that mean? Well, that can happen over time, but it can also mean that you've had a re-injury without an obvious tear, and that can sometimes be read as a degeneration. So you would need a consultation to see if there's any instability that's detectable on physical exam, and how you feel about your knee also matters. If you feel a subjective sense of instability, again, people can sprain ligaments, sprain grafts, and also remember the MRI is the best at showing tissues that are separated and torn, right? So if you have a situation where you have plastic deformation, or what's called I don't know if you guys can see me on the screen, a tear in continuity, which means that you have a tear, it did this, and it stretched out, but it's still, quote, intact, and that the MRI can't tell the difference. And so in that case, if it's stretched out by 2 millimeters and you're doing a Lockman and a anterior drawer, and you have 2 millimeters of play, compared to the other side, even with ferment point, and if that's a new finding, then that's concerning, and you would have to do a pivot shift exam. Typically, the pivot shift with the patient supine is difficult to elicit a true pivot. I like to use a sideline pivot shift of Slocum, and so for those of you who are clinicians or physical therapists and ATs, feel free to come shadow my clinic, and I'll show you how to do that. It relaxes a patient, and you can elicit a pivot much more easily and frequently and consistently than if you have the patient supine. Because if I've seen people hold a leg like as if they're wrestling an alligator. If you do that, the patient is not going to relax. They'll tighten up, and there's no way that you're going to elicit a pivot, even if they otherwise would. Okay. Bree, how long will be to return to full sports activities? And does a rehab time frame is different based on the type of graft that was used? Yes. So patellar tendon graft has a bone, tendon, bone component. So if you have a bone tunnel and you put a piece of bone in there and you put an interference screw, you're going to get bone to bone healing. And that healing is faster than soft tissue to bone healing, right? So you put a quad graft in there or a hamstring graft in there, it takes longer for soft tissue healing to bone in the same way that rotator cuff tissue healing to the greater tuberosity footprint takes a long time because you have not only the synovial fluid, but you have two different materials. So the analogy I use to people, use with patients is that, intuitively, all of us have learned in grade school when we're in our wood shop class, that if you have 2 blocks of wood and Elmer's glue in between and a vice grip, that's going to set a lot faster than if you have two different materials. So if you have a block of wood and a block of metal, Elmer's glue and a vice grip, that's going to take a lot longer to set, right? So the same thing in our bodies, and it takes a while longer. Allograft takes longer to incorporate than autograft. So that's the timing for it. And how long to return to full sports activities, as we mentioned in the slides. If you meet all of the milestones in the ACL functional screen, all the timed hop tests and cross hop tests and triple jump hops, Y balance beam, quad girth greater than 90% of contralateral side, and a bunch of other different metrics, plus 9 months from the time of surgery, that combination has been demonstrated to yield the greatest success. So there have been reports of people who were able to pass their ACL functional tests at 6-7 months, and they were allowed to return back to basketball, and they felt fine, but they had a persistent effusion. So get a repeat MRI, guess what? ACL graft is torn. So it does need time for maturation. You've seen in that graph that starting about week 5, the grafts get weaker than the native ACL, whereas in the first month or so, the graft is stronger than the native ACL. So it takes a long time, and it's a slow progression from a weakened state to get back to the original strength of the ACL, and that's been shown to take between 9 to 12 months in most people. Okay, Jacob Roberts, I also have a question. Do you have any comments about an ACL repair with an internal brace? Yeah, so internal brace is the technique that's been popularized by a specific company, as you know. There's some controversy between an ACL repair as a technique versus ACL repair with an internal brace. And for those of you who are not sure what an internal brace is, basically you put in a big tape suture and attach it to the femur and the tibia. So in addition to the ACL, you're using this suture tape, fiber tape it's called, as an additional strut, if you will, to protect the tissue from tensile forces while it's healing. So the use of internal brace has started to creep into other areas as well. Some people will use an internal brace even when they're using a graft. So there's ACL repair, where you just take the torn portion and reattach it to the bone. There's ACL repair with this spanning suture, if you will, called the internal brace. There's an ACL repair with additional collagen augmentation that you can put in there. I'm not sure if I'm able to use proprietary kind of names on this lecture, but I guess it's not a CME granting one, so I guess I could. But so there's some controversy. So the folks will say, hey, it's not the added augmentation stuff that you put in there. If you just use sutures and just repair it, that's good enough. And the other company that makes the additional biologic augmentation will say, no, that's what really what gives it the additional strength, if you will, or success rate for healing. The problem is that that company is still in clinical trials right now, involved in non-inferiority studies. So they've demonstrated that it's non-inferior to a hamstring graft. and they're currently involved in doing a non-inferiority study against the patellar tendon. So take, for example, myself, where I prefer the patellar tendon graft. So unless there's a study that shows that this other technique is actually better than the patellar tendon graft, I'm not quite ready to switch yet because I prefer the patellar tendon over the hamstring. So if another technique says, well, we've demonstrated that we're just not inferior, we're not necessarily better, but we're not inferior to the hamstring, they still need to meet additional metrics for me to make a switch. All right. Should I recommend my 62-year-old female client who wants to get into pickleball to get her meniscus repaired? Okay, we're going to different tissues now, but okay. Can she pivot with a torn meniscus? Currently, I'm focusing on strengthening mobility, range of motion with her. So the meniscus tears would be a whole entire lecture on its own. So there's so much that goes into this. 62-year-old, it's kind of a loaded question, right? So how much degenerative changes? What does the articular cartilage look like? Is she playing pickleball like me, or is she playing pickleball really well? So those are all things that matter. There's some people who want to really be competitive, and there's some people who just want to go out there and just kind of enjoy themselves and have fun. And so I think that's different. And what are her symptoms when she's playing pickleball? If she's currently not able to play, has pain and swelling, and gets in the way, then she might need to get that looked at. And the other question is, it's unclear where the tear is located, what configuration is it, where is the tear exactly, medial versus lateral, as well as anterior horn body and posterior horn. So it's possible that she may not be a candidate for repair anyway. She might just end up getting a meniscectomy. So again, hard to answer that without more additional information. All right. Michael's back. Is the Lachman test an additional indicator for surgery requirement on top of the Cooper's program? Basically, if a doctor assesses full stability of the knee through Lachman, could it mean that surgery is not needed, respectively? Could it mean that MRI results might have not been interpreted correctly? It was assessed as a torn ACL. It might have been only been a partially torn. So, so again, we have so many different ways to get information, right? So I don't think is the Lachman is the end all be all test. Remember, you can have people who had a vertical tunnel placed for an ACL reconstruction. They will have a normal Lachman and a normal anterior drawer, but they will have a positive pivot shift, because if you put the graft in vertically, right, then it's like a pole. You can rotate around that, can't you? But their Lachman and anterior drawer will be normal. So for me, the assessment is all of those things, but you need a pivot shift. I need to understand what the pivot shift looks like. So the Coper's program is not designed to say, hey, we just want you to be able to run front and back and not turn any corners or do any cutting. That's not what a Coper's program is, right? So if they are rotationally unstable, they're not a Coper. They need surgery or surgery. So that's how that's assessed. All right, Nadine. Someone has a reconstruction with fails. Would you use an autograft from the same knee or the ipsilateral knee? So it depends. So if they had their first surgery with a patella tendon autograft, and I'm doing a revision redo, I would talk to them about using a quadriceps autograft from the same knee or a patellar tendon autograft from the contralateral side. I didn't know if you had any follow-up questions to that, but anyway, that's what I would do. I don't like using hamstring as a revision graft source personally. The other thing I guess I should mention, because now I see that we are getting some more sophisticated questions here, and people are probably, physical therapists and clinicians and ATs, because I thought this would just, people from the community coming for this talk. So, as you know, there's an optimal quad hamstring ratio that we want to try to achieve. A lot of the different sports that people are involved in that have the hard cutting, pivoting nature to it are very quad dominant. And a lot of, especially female athletes, have a quad dominant status. So for me, another reason why I don't like taking the hamstring, this might be more philosophical, is that you take the hamstrings, then you will forever create that quad hamstring imbalance. And so by taking the patellar tendon or the quad tendon, you know, restore the hamstring and can perhaps still try to achieve the desirable quad hamstring ratio. So that's just another subtle little thing now that we're getting deeper into this. Hmm. If a knee just gave way, impact, wouldn't that already be enough indication that one is not eligible for is that the non-contact ACL rupture patients, most of them would not be eligible for the COPERS program. Having said that, it's not a decision I make in the first meeting when they have a swollen knee that they can't even move for me to examine. So I give them the benefit of the doubt, which is why I'm always constantly trying to give everyone a chance that as reasonably that is possible. So the best way to assess that knee stability is when they don't have pain, don't have swelling, has normal gait, has full range of motion, went through physical therapy. And at that time, granted, I don't have very many people that go through the COPERS program. Most of them end up having surgery. But the few people that do make it into the COPERS program, there's some caveat as well, is that, you know, there's a certain percentage of you that'll cross over and will need surgery later. But I tend to agree with your sentiment, Michael. But all I'm saying is that I want to give everyone an opportunity to demonstrate to me that they have an option to enter the COPERS program if at the time of reassessment, they look really good to the point where I say, your current physical examination is where I would want you to be as my target after I do surgery on you. So if they are demonstrating that, you know, their pivot shift is, you know, a pivot glide barely, and Lockman and anterior jaw is normal, and their quads are firing amazingly well, you know, and I explained to them, hey, there's still a risk that you might need to come back and have surgery, but if the patients and or the parents are interested in that pathway, it's something that we explore. I have to admit, you know, even after conversations about the COPERS program, quite frankly, many young athletes and their parents still choose surgery. And the people who choose the COPERS program tend to be, as I was joking around before, tend to be more experienced in life like myself, you know, so 6 decade of life in their 50s or 40s. Melissa Turner, do you treat younger teens like 13? So for certain conditions, I see young athletes from age 10 and up, but for ACLs, I take care of those from 14 and up because I perform physeal sparing ACL reconstruction surgery, but I don't do the non-anatomic surgery that completely avoids all of the growth plates. So personally, I'm more in favor of anatomic reconstructions rather than non-anatomic reconstructions. As you guys may know, I came from Boston, and you know, Boston Children's Hospital has a great track record of performing non-anatomic ACL reconstructions for really young folks with open growth plates as young as 8 years old. They've had some great results. As a result, so I don't really venture into that age group. Stacy, hello there. If a Sagand fracture is present, would the LET be best practice? So if the Sagand is there, that's a good question. It could be argued, depending on the patient's physiologic laxity and degree of hyperextension, that perhaps a well-done ACL reconstruction may be sufficient. But if after you do the reconstruction and the knee still hyperextends or has other rotational issues, then I think doing an LET is a great option, personally. And in patients like that, the other important thing is to assess if doing these soft tissue reconstructions is sufficient, meaning the posterior slope of the tibia has to be evaluated to make sure that we're not trying to fix a bony problem with soft tissue augmentation. Do you work directly with the physical therapist to determine return to play? I would say it's indirect. I rely heavily on my physical therapy colleagues to do the assessments and have the report uploaded into Epic so that I may review them. We communicate about athletes who are going to see me after the ACL functional screening tests have been performed. We're coming to see me for clearance, and I get a heads up text that says, hey, this kid is actually not ready. And that helps me a lot. And I credit all of my physical therapy colleagues for taking care of me that way. Because I don't know anyone better than the patient's physical therapist who are holding the tissues in their hands, week to week. And I rely on their assessment and judgment so much that I would say realistically, it's really, an informal assessment on my part, or a passive one, I should say. And I rely heavily on the work and the relationships that our physical therapy colleagues have developed with the patient. So yeah, honestly, I'm not directly getting involved. I'm just looking at the results and interpreting them and making decisions together with the physical therapist, because usually they tell me, hey, this kid's ready to go. Then it makes me feel a lot better to say, hey, the numbers look good, and your physical therapist also has confidence that you're ready. And the other thing that we're going to start doing at both Rothman and Advent Health is to incorporate the psychological readiness to play scales as part of the ACL functional movement screens, to incorporate that as well, so that they can give me a heads up about both. And that would really be, I think, a really nice comprehensive way to do it together. All right, if the patella tendon graft is a graft of choice, well, let me clarify, just for me, right? So I don't want to speak for other surgeons or or claim that I know what the best graft is. There is no best graft. That's just my personal preference. I have close friends of mine where we, debate each other all the time. I have friends who are big hamstring advocates, and I have friends who are quad advocates. And I've also, had conversations many a times with Dr. Sherborne, who, as you know, ipsilateral patellar tendon is his preferred graft. Is there a way to avoid the anterior pain and kneeling pain associated with the graft? So the anterior knee pain and kneeling pain, I don't know how often you encounter it, but I don't really encounter it that very, very often, to be honest with you. Part of it is that, excuse me, when we take the bone plugs from the patellar side and the tibial tubercle side, we take the excess bone and we save it, and then we pack it into the patellar defect. And that helps to decrease the fracture risk, and also really helps with reconstituting that defect into bone. And my mentors from residency at hospitals for special surgery, as well as my fellowship mentors from Mass General and Mayo, as well as my colleagues when I was practicing at Mass General and the Brigham, when you do the bone grafting, the incidence of anterior knee pain was nearly undetectable. And having said that, if I have a patient who's a plumber, carpet installer, or a religiously devout person, I do tell them there's a small risk that this might happen, and we start talking about using a quad graft in that setting. Okay, Michael, at which point can I be certain? Well, whenever you start a question like that, I guess the question will be, you'll never be certain about anything in life, right? We're only human beings. What are we going to do? At which point can I be certain about an ACL knee surgeon? What's a good number of the surgeries that one should have had? Number of first reconstruction surgery, number of second reconstruction surgery. What other criteria can I apply to make a decision for a surgeon? That's actually a very good question. If we look at literature from other surgeries, say where things go pretty routinely, like knee replacement, hip replacement, shoulder replacements, typically there's a learning curve. And in the shoulder arthroplastic literature, if they perform fewer than 25 shoulder arthroplasties a year, they have significantly higher complications, significantly higher revision rate. So so that literature comes to mind. I'm not aware of a study that was done with ACL reconstruction. I will tell you that when I was in training, I went to, as part of our rotation, went to a community hospital, and locally there was a surgeon who performed a high volume of ACL surgeries. And I was a fourth-year resident, and I had finished my sports medicine rotation at HSS. And I was at that community hospital to do trauma. I was the acting chief resident of trauma, taking the junior residents and through taking care of trauma patients. And every time I was there, this person called me into his room to have me help. And it turns out that this person did a high volume, but based on my evaluation, was putting in vertical tunnels. And there was virtually every case had a graft tunnel mismatch, like the graft was sticking out and was too long or too short. So I don't think volume itself is sufficient to determine if the surgeon has successful outcomes, because there are some surgeons who just do the suboptimal thing just many, many more times. So I think, as part of what we do at Rothman and Advent Health is our physical therapists, for those who are interested, we had many who shadowed me both in clinic and in surgery. So you get to understand some of the dynamics of patient relationships and developing the trust in clinic, and how to approach problems, break them down, take complex problems and break it down into simpler problems to solve them. How to counsel people, how to collaborate with physical therapists and athletic trainers, and then also, observe surgery and see how things run there. I think it takes a relationship, right, to really figure out, how reliable the surgeon is. If you're only looking for a technically really good surgeon who doesn't communicate with the physical therapist or doesn't treat the patient nicely, I think that all goes into it. And so, yeah, how do you, quote, become certain, as certain as we can be? I think it's to assess someone based on all of those things, not just their technical skills, but their character and their communication skills and their willingness to be collaborative. And so, those are just some of my feelings there. Is that it, guys? Is that the last of the questions there?
I think so. So thank
Awesome.
you all for taking time out of your schedule to join us this evening. And thank you to Dr. O for sharing such valuable information. I hope you all found this information helpful. And if you still have any questions, please email me, which you will find in the chat box, and we'll get back to you as soon as possible. Again, if you would like to make an appointment, please call 1-844-407-4070 or go to rothmanortho.com. Thank you,
Awesome.
Dr. O.
My pleasure. Thank you, everybody. Thanks for joining. Have a great night.